Okay, oncology now, general information. Alcohol plus tobacco are co-carcinogenic. Y'all, you're going to see as we go through this section that there are several different cancers that if you have alcohol and smoking in the presence of each other, that just makes everything a lot worse. It makes cancer develop a lot more rapidly. So that's why we say they're co-carcinogenic. Tobacco is the #1 cause of preventable cancer. I think we already know that. Suspected dietary causes of cancer. Well, a low-fiber diet for one thing. You see, with a low-fiber diet, you don't have as much motility in your intestines, so therefore you're retaining carcinogens longer. That's why they want us all to be on a high-fiber diet, all right? We're going to talk more about that in just a little bit. Increased red meat consumption, increased animal fat, nitrites like in sandwich meat, processed sandwich meat. There's alcohol again, and then preservatives and additives. You know, really the big push is to eat all natural foods, whole grain foods, things like that with no preservatives, organically grown, that sort of thing is the very best. Now, there's an increased incidence of cancer in the immunosuppressed. That is why there's a higher incidence of cancer if you're greater than 60. You know, the older you get, the poorer your immune system is, right? Okay. Now, let me talk about the immune system. You know, right now in our body, all of us have cancer cells right now. But we have a good immune system, so what is our immune system able to do? Recognize those cancer cells and destroy them. However, when you become immunosuppressed in any way, then your immune system can't fight those cancer cells as well. That's why eating healthy is also very important for building up your immune system, too. Now, the most important risk factor for cancer is aging. It's just the fact of life. The older you get, the greater the chance it is that you're going to get cancer, simply because you've had cells in your body for so much longer, and there's mutations that can occur, and DNA can get messed up, and then cancer can expose itself. But also, you got to remember that the older you are, the longer you've been exposed to environmental toxins too. So your risk for cancer increased. Cruciferous vegetables such as broccoli, cauliflower, cabbage are very good. Vitamin A foods, that's just the way I remember vitamin A foods is anything with color to it, whether it's squash or a red bell pepper or something like that. That's a colored vitamin A food. Carrots. And vitamin C could decrease risk. African Americans have a greater incidence than Caucasians. On that, they don't really know why. There's no specific factor that tells what the etiology is behind that. Primary prevention, that's a term we hear used a lot when you're studying cancer. These are ways to prevent the actual occurrence of cancer, like using sunscreen and just never smoking. And then we have secondary prevention, and that's when we use screenings to pick up on cancer early when there is a greater chance for cure or control. Now, chronic irritation brings about uncontrolled growth of abnormal cells. Irritation. For instance, if you have a mole in a spot that is constantly being rubbed by clothing, that's irritation. Smoking is an irritation to your lungs. So there's lots of things out there that can cause irritation. Chronic reflux, somebody that always has trouble with gastroesophageal reflux disease is at a higher risk for esophageal cancer because that's irritation. Now, let's look at some prevention things here. First of all, the female monthly self-breast exam. Everybody knows how important that is. Once a female starts their period, they should be taught to start doing the monthly self-breast exam. Now, on what days of the menstrual cycle is the best time for doing the self-breast exam? Ask your friend. Day 7 through 12. Anytime through day 7 through 12. The key is this. After the period is just about over with, you would never want to do the self-breast exam prior to the period because that's when you're going to have a lot of swelling and tenderness, and they're not going to get a good exam that way. So it's after the period is really just about over, anytime between days 7 through 12. Now, if you've got somebody who's postmenopausal or has had a hysterectomy, of course, they're not having a period. So what you do is you teach them just to remember a certain day. Like, what's your birthday? Okay, it's February the 17th. Okay, the 17th of every month, you need to remember to do a self-breast exam. All right. Also, yearly clinical breast exam for women greater than 40 years of age and between 29 and 30 needed every 3 years. Now, when I say a clinical breast exam, I mean in a doctor's office setting, okay? Annual pelvic exam is needed, and a pap smear is really only needed every 3 years if there's been no problem, according to the American Cancer Society. But most of the time we get those yearly anyway because you're going to the doctor having your yearly pelvic exam and that sort of thing, so they just go ahead and do the pap smear anyway. Now, there are 2 things you should instruct your patient not to do prior to having a pap smear. Ask your friend what those 2 things are. I heard somebody say it. No douching, first of all. A lot of people are like, oh, I've got to have a douche before I go to the doctor. No, that messes up the cervical cells. The only time that someone should use a douche is when it's been medically prescribed, okay? That messes up the cervical cells. And also, no sex prior to a pap smear. Y'all, you don't want other things on the little slide. Now, do you? Ask your friend, okay? Anyway, okay. Mammogram, baseline at 35 to 40, yearly after 40 with 2 views of each breast. Okay, now before a mammogram, what should you tell the patient not to have on their body? Ask your friend. No lotion, no powder, no deodorant. No lotion, no powder, no deodorant. You see, when you have lotion or powder or deodorant on, that could be picked up on the mammogram as a calcium deposit. It looks like a calcium deposit, and most of the time when we see a report where the patient has a calcium deposit, that usually means cancer. So see, that would alter the test. Now here's the deal though. Most women have not been told that prior to going to get their mammogram. So the first thing they always do when they get there is they give them a washcloth and they tell them to bathe off really, really well to make sure they get all the lotion and deodorant or powder or whatever they have on off of the body. And then a yearly colonoscopy at age 50, then every 10 years after that, if there's been no problem. Now, the more problems you have, the more frequent you have to have those sorts of things. All right. Now, for the male, they also need to do the monthly self-breast exam. Same type of procedure is going to be done. And then a monthly testicular exam. Now, monthly because testicular tumors grow very fast. Now, the major age group that gets testicular cancer is between 15 and 36, so young males. This is something that needs to be taught early on, and it needs to be done. Be sure and teach the patient to do that monthly because testicular tumors do grow so fast. Yearly digital rectal exam and yearly PSA for men over the age of 50. We're going to talk more about that later. And then a yearly colonoscopy at age 50 and then every 10 years. Now, caution. I'm not going to read all of those to you. You know what those are. Those are warning signs is what they are that need further investigation. If somebody has any of those things, those things need further investigation. Cancer can invade the bone marrow, which can lead to anemia and thrombocytopenia. So if you ever got an anemia question, you know you're just really focusing in on hypoxia, right? Okay. And then also if you've got a thrombocytopenia question, you've got somebody who's going to bleed. And we're going to talk about bleeding precautions later in the week, but you know what those are. Use an electric razor, use a soft toothbrush. If it's a child, quiet play, you know, because you don't want them playing too rambunctiously, that sort of thing. No IMs when you have bleeding precautions. Cachexia is another term that we hear used when we're studying cancer. That means extreme wasting and malnutrition. You may hear somebody be described as being cachexic. That's usually seen close to death when the patient's not able to eat anymore and they've just lost lots and lots and lots of weight. Sometimes you'll see that word used in the doctor's progress notes. Now, let's talk about radiation therapy for a while. And we've got 2 different types here. We've got internal and we have external. Let's talk about internal first. Now, another word for that is brachytherapy. With all brachytherapy, the radioactive source is inside the patient and radiation is being emitted. You have 2 types. You have unsealed and sealed. Now, unsealed, this is when the patient emits radiation, as does the body fluid. Okay? This is when an isotope is given IV or PO, and it's usually out of the system in 48 hours. So this is a real short-acting deal. When I think of this type, the first thing I always think of is somebody that's being treated for hyperthyroidism, and they give them the isotope where they inject them. We're going to talk about this more tomorrow. And they're radioactive for 48 hours, and then they're okay. Okay? But it can be used for cancers, too. Now, the sealed or solid, patient emits radiation, body fluids not radioactive, implanted close or in the tumor. Y'all have heard of them placing radioactive seeds into people or needles, that sort of thing, directly into the area. That's what we're talking about here. All right, so let's say you get on the test and you just can't remember all these different details about which one emits radiation and which one doesn't. In general terms, do radiation implants emit radiation to the general environment? If you were just thinking in general, as a brand new nurse, what would be the safest thing for you to say here? Yes, just pretend that they all do. If you can't remember all the details is what I'm saying. Yes, they do. You know, there's some, like I said, some do emit radiation, some do not. They do not expect us to be oncology experts. So if you get in a bind in a test question, just pretend they all emit radiation, and you'll be safe that way, because thinking like that, you won't hurt somebody, okay? All right. Nursing assignments should be rotated daily so that the nurse is not continuously exposed, and the nurse should only care for one patient with a radioactive implant in a given shift. You're not supposed to assign, well, let Sue take care of 3 radioactive implants today, okay? That's not nice, okay? Now then, precautions. Well, a private room is needed. Restrict visitors. No visitors less than 16 years of age. No pregnant visitors or nurses. Be sure and mark the room. They need to wear the little badge that tells how much radiation that they're getting, and they'll keep up with it like that. And you don't give your badge to somebody else and say, okay, now you wear it a while, because you're not going to know exactly how much radiation somebody's been given. I've seen test questions like that before. Limit each visitor to 30 minutes per day, and the visitors must stay at least 6 feet from the source. Now, as nurses, sometimes we have to get close, right? But this is why your teacher told you when you were studying radiation, especially internal radiation like this, they told you to get your act together before you went into the room, right? So you go in the room and get what you have to get done, and then you hurry up and get out. That's also why these people get so depressed. It's because they're by themselves all the time, okay? So we have to consider that when we're taking care of these people. Another important thing to keep in mind is dislodgement. How can you help prevent dislodgement of the implant? Well, you keep the patient on bed rest. You decrease fiber in the diet. Fiber. Now, the reason for that is this. If you've got somebody that's eating a lot of fiber, that's going to distend their bowel. And when you distend the bowel, you could push out the implant, you see. All right? So they need to be on a low-fiber diet. But also, we want to prevent bladder distension. Distension, that's why they'll just about all have a Foley catheter, to prevent bladder distension. Now, what do you do if the implants become dislodged, and there you can see it? It's glowing in the bed. Tell your friend what you do. Well, if you can't remember what to do, put on gloves first, right? Always put on your gloves first, and then you pick it up with forceps or tongs and place in a what? Lead-lined container. Lead-lined container. You do not take it out of the room. You call the radiation people and let them come and get it. You see, the implants people want to make sure you don't find something glowing in the bed and stick it in your pocket, okay? And then walk out to the nurse's station later and show all your friends what you found in the bed while you radiate everybody, you see? Part of NCLEX is not just protecting the patient, it's also about, do you have enough sense to protect yourself and the other people that you work with, too? All right. Now, don't forget this patient is immunosuppressed as well, okay? So anytime you're thinking about somebody that's immunosuppressed, do you have to consider the type of patient that would go in the room with them? Yeah, but with this person, they're in a private room, okay? But if on NCLEX, they put you in a bind and you had to select somebody, just remember that you would never put in somebody in there that had an infection with somebody that's immunosuppressed. That's just a general rule. But this person is going to be in a private room because they're radiating to the general environment. Now, external radiation, also called teletherapy or beam radiation, the usual side effects. usually limited to the exposed tissues. For instance, when you have this type of radiation, that's when they're going to be radiated in the same spot every day for so many days. And that one little spot's going to get really dry, and maybe the skin may start breaking down. So, of course, they're going to be symptomatic at the site. Also, if you'll drop on down a couple of sentences, it says many signs and symptoms are location and dose related. For instance, if I have a brain tumor and they're radiating me here, that's when I'm going to lose my hair, have impaired taste, and sores in the mouth. It's very local to where they're radiating you. Other symptoms just in general, erythema, shedding of the skin, altered taste, fatigue is a biggie, and pancytopenia. Pancytopenia is when all of the blood components are decreased. Your RBCs, your platelets, and your white cells. Everything. Pan means everything. Okay? Now, is it okay to wash off the markings? No. Is it okay to use lotion on the markings? No, they don't want you to put anything on the markings unless it's been ordered by a doctor. We're protecting those markings. They've been put there for a very important reason. And also, protect the site from sun for 1 year after completion. Well, it makes sense that you would want to protect it while the area is so inflamed, right? But they have to continue protecting that site for several months later because it's still very fragile there. Now, chemotherapy works on the cell cycle. I bet in school your teacher went into a lot of detail about the cell cycle and all the different phases that the cell goes through when it's living, okay? And different chemo drugs work in different phases of the cell cycle. Like this drug may work in S1 and this drug may work in S3. When you're using multiple drugs, we call that combination chemotherapy, where you're trying to kill these cells in different phases of their life cycle, okay? Now, usually scheduled every 3 to 4 weeks. And, in between their chemo, they're basically recuperating, aren't they? Because that round of chemotherapy can knock people out for a week. And then they're telling them, now look, be sure and eat good this next month while you're off, because when you come back, we want to make sure your blood's built up and everything. Well, they're so sick, they can't eat. All right? So it's a vicious cycle they get into. Most chemo drugs are given IV. They usually have some type of port, right? Because their veins get to be so teeny tiny and hard to stick, and it's just easier on the patient to have a port. Many chemo drugs absorb through the skin and the mucous membranes. So you have to be very careful when you're handling them because you're absorbing it too. So be sure and use your gloves and read about each drug to make sure that you're handling it the right way. Now, the usual side effects are, well, the first thing most of us think about is alopecia, hair loss. Not all chemo drugs make you lose your hair, but a lot of them do. Chemo drugs attack the cells that are dividing most rapidly, okay? Because cancer cells divide real rapidly, don't they? Well, so do your hair follicles, and that's why hair loss is so prominent with many chemo drugs. Other things, nausea, vomiting, mucositis, that's just sores in the mouth, sometimes called stomatitis. Immunosuppression is a biggie, as well as anemia and thrombocytopenia. All right, a patient's WBC count must be at least what before they will receive their treatment? 3,000. 3,000. Now, I know what you're thinking. That is very low, isn't it? Because normal white counts 5,000 to 10,000. But if I'm a cancer patient receiving chemotherapy from time to time, I'm going to be lucky if I can get a white count of 3,000, aren't I? Yeah. Yeah, I'm still immunosuppressed, but I'm doing well if I can get a white count of 3,000. What would happen if I went to the doctor, the oncology doctor, to get my chemo, and the nurse forgot to check my white count, and it was less than 3,000, they went ahead and gave me my chemo anyway? What would happen to my white cells that I had left? You knock them out too, right? Yes, that's very dangerous. A vesicant is a type of chemo drug that if it infiltrates, now we say it extravasates because it's a vesicant, will cause tissue necrosis. Eat the tissue. Now, what are the signs and symptoms of extravasation? Well, if your tissue was being eaten away, what would be your first complaint? Pain. That's the first complaint. Pain, swelling, and no blood return. No blood return. Anytime you are giving a chemo drug, you need to look it up to see if it is a vesicant or not. If it is a vesicant, you must stay with the patient the entire time they are receiving the vesicant because they are so dangerous. So much of the tissue can be eaten away that they have to have a lot of grafts done to the extremity and plastic surgery. It's very dangerous. The number one thing to remember with extravasation is prevention. You never want it to happen to begin with, but things do happen. Well, what do you do if someone does extravasate? What's the first thing you should do? Stop the infusion. Stop the infusion. Now, if you had to pick, would you choose ice packs or warm, moist heat? Ask your friend. Ice packs or warm, moist heat? Okay, now tell me. Most of the time, when a plain old IV infiltrates, we use warm, moist heat to decrease inflammation. But if you put warm, moist heat here, it's going to make the vesicant spread. So we prefer ice packs here. Ice packs here. Now, y'all, in your med-surg books, they will say certain drugs require ice packs and certain drugs require warm, moist heat. But see, I got to think NCLEX. I'm a brand new nurse with 2 weeks of vast nursing knowledge. Do you think they really expect me to know all these details like that? Because I'm not an oncology nurse expert. So the safest thing to know here is if you don't know anything else, ice packs, okay, to promote vasoconstriction. I don't want it to spread and eat more tissue. And of course, you got to call the doctor. And they also have what's called extravasation protocols. A protocol is in place so you won't have to waste time, right? Because the longer you waste time, the more tissue's being irritated. And that's with the extravasation protocol. You may inject the site around the area with bicarb to neutralize it. Then they've got vasoconstricting agents you can inject in there, like Regitine, that'll vasoconstrict. So there's lots of protocols out there in the world that can be implemented as well. Now, another thing we have to think about when we're thinking about somebody with cancer and chemo is immunosuppression and infection. So here we go. Of course, they need a private room, wash hands, we know that. Have own supplies in the room. They need their own cups, their own everything you can think of. You don't need to go to a general closet and get a supply for a patient, like pull out a cup or something like that. They need their own blood pressure cuff in the room, their own stethoscope in the room, their own stuff, because you only want their bacteria in the room. Limit people in the room, visitors and nurses. Change dressings daily and IV tubing daily. Cough and deep breathe. You don't want them to get pneumonia, right? They're already at higher risk than the normal population for pneumonia, so we're kind of overcompensating with this person. No fresh flowers or potted plants. There's a lot of bacteria in those things. Avoid crowds. Do not share toiletries with anybody. Bathe warm, moist areas daily. Twice a day, usually is what they say there, like under the arms, the groin area, that sort of thing. Wash hands after touching a pet, or they even say after you shake hands with people, which we know that. Avoid raw fruits and vegetables. That's a lot of bacteria and that sort of thing. Drink only fresh water. They say if there's a cup of water that's been sitting by the bed for more than 15 minutes, it's old, okay? Consider that water to have some type of bacteria in it. We want fresh water always. Slight increase in the temp may mean sepsis. You see, in someone that's immunosuppressed, you may not see a spike in the temp. You look for lower increases. And an absolute neutrophil count is the most important piece of lab work because, as you know, that's a type of white cell, isn't it? Now, let's move into some different types of cancer, specific types of cancer. And the first one that we're going to talk about is cervical cancer. Risk factors, sex or pregnancy at a young age, and repeated STDs. Well, repeated STDs would be irritation, wouldn't it? Yeah, chronic irritation. And then when sex at a young age and pregnancy at a young age, well, people will say, well, what's considered to be a young age? Well, that depends. It depends on when that person's period started. You know, you may have someone who didn't start their period till they were 16, and then you may have somebody that started their period at age 12. Well, really, the age 12 person is more mature reproductively than the 16-year-old because they've had a period for a longer period of time, okay? Often asymptomatic and pre-invasive cancer. You know, when that cancer starts getting out into other organs in the lymph nodes, of course you're going to be more symptomatic. The invasive cancer classic symptom is painless vaginal bleeding. Other symptoms, watery blood-tinged vaginal discharge, leg pain along the sciatic nerve, and flank and back pain. The sciatic nerve pain is just due to pressure, okay? 100% cure if detected early. And what is the test that helps diagnose this? It's called the Pap smear. Anytime you have an abnormal Pap smear, they repeat it, don't they? Yes, I always repeat abnormal Paps. Now, treatment, electrosurgical excision, laser, cryosurgery, radiation and chemo for late stages. They can do something called conization, where they just remove a part of the cervix. That's for somebody who wants to preserve their fertility, okay? And also it depends on the kind of how advanced your cancer is. Sometimes they can't just go in there and take out the piece of the cervix that's affected. They have to do a more radical type surgery. And then a hysterectomy may be done too, which we're going to talk about in just a second. It just depends on how invasive your cancer is and what stage they catch it in. Now, uterine cancer, risk factors. Greater than 50 years of age, the older you get, right? Positive family history, late menopause, and no pregnancy. Anybody who has struggled with infertility or has never been able to get pregnant always has a higher risk of reproductive type cancers. Major symptom, postmenopausal bleeding. In other words, you've got somebody who's already been through menopause, and then they report that their period started one day. There's a 50% chance it's cancer when that happens. So they need to be taught, hey, if you ever start your period again after you've gone through menopause, you need to report that to the doctor immediately. Other signs and symptoms, again, watery, bloody vaginal discharge, low back or abdominal pain, pelvic pain. Now, diagnosis. One way they look at this is with the CA-125, which is just a blood test. And the reason they do that is to rule out any ovarian involvement. You know, in these women's magazines, they always talk about getting a CA-125 done. CA-125. But really, a CA-125 can't predict that you have cancer. It may or may not be an indicator. Now, tests to evaluate for metastasis would be chest x-ray, IVPs, barium enema, CT, liver and bone scan. The most definitive diagnostic test is a dilatation and curettage and endometrial biopsy. Now, treatment. Hysterectomy, total abdominal hysterectomy. Total sounds like they're going in there and taking out everything. But really, they're just getting the uterus and the cervix with the total, okay? If they want to get the tubes in the ovaries, other things have to be written on the op permit as well. Bilateral oophorectomy, bilateral salpingectomy, okay? Now, with a radical hysterectomy, they may remove all of the pelvic organs, okay? So your patient may wind up with a colostomy or an ileal conduit where they had to take out the bladder too. The greatest time for hemorrhage following this surgery, and we're talking just abdominal hysterectomy in general now, okay? The greatest time for hemorrhage following this surgery is during the first 24 hours. Why? Pelvic congestion of blood. Pelvic congestion of blood. Just due to the nature of the surgery, you've got a lot of blood rushing to the pelvis, okay? Now, let me tell you something. The major complication of an abdominal hysterectomy, is hemorrhage. This sitting on your handout, I'm just talking. Abdominal hysterectomy, think hemorrhage. Vaginal hysterectomy, think infection. Vaginal hysterectomy, think infection. All right, the next statement says, we'll probably have a Foley. If she doesn't, you better make sure she does what in the next 8 hours? Voids. Anytime somebody has had a surgery, y'all, you know if they don't have a Foley catheter in place, you need to be checking for bladder distension because they're still out of it from the anesthesia, that sort of thing. They may not be able to recognize when they need to void. That's very important, especially important here because why is it so important to prevent abdominal distension after this surgery? Because we do not want tension on the suture line. We do not want tension on the suture line, because this can lead to wound dehiscence and evisceration. So, if you go in the room and the wound, the incision is separating, all right, that's dehiscence. But if you have organs actually coming out, that's evisceration. So you walk in the room and you look under the dressing and the patient is eviscerating. Tell your friend what you would do. Go get somebody that knows more than me? No, don't leave the patient first, okay? That's the first thing I want you to remember. Don't leave. Now, it's okay to get on the call light and tell somebody to come help you, but you need to make the NCLEX people happy and reassure them that you're not going to leave. Now, what if it said as an answer to hold slight, gentle pressure with sterile gloves on? What would you say? What are you telling the NCLEX people you're going to do? I'm going to push it all back in, okay? All right. No, you don't do that. No pressure. You put 4x4s all over it, sterile saline 4x4s to keep the area moist, and call the doctor, and we've already agreed that we're not going to leave the patient. Now, why do we avoid high Fowler's position in this patient? Because that'll make more blood go where? To the pelvis. To the pelvis. We don't want more blood going to the pelvis. And they may have an abdominal and a perineal dressing to check. So just know that you may have two dressings to check. Okay? As this patient is at risk for pneumonia, thrombophlebitis, and constipation, what is one thing you can do to prevent these complications? Ask your friend. Tell me. I heard cough and deep breathe. I said I wanted to know one thing. How does coughing and deep breathing help constipation? It doesn't. That's why I made you pick one thing. Early ambulation is the answer here. Early ambulation will hit all three of those things. Don't get me wrong. I like coughing and deep breathing. But I was trying to make you pick one answer that would hit all of them, okay? Now, avoid sex and driving. Now, let's get one thing straight. I don't mean at the same time, okay? I mean for a period of time after the hysterectomy. Also, avoid girdles. That's just going to cause more pelvic congestion. And also, stay away from the douche infection is what I think of there, okay? Any exercise, including lifting heavy objects that increases pelvic congestion, should be avoided. What if you've got somebody who has small children at home? Should they be picking up their children? No, because when you pick up too much, you're going to bleed. Is it possible that the patient could hemorrhage 10 to 14 days after this surgery? Yes, or I wouldn't have typed that big long sentence. Now, would I? That's right. It's been there for a reason. It's in there for a reason. Yes, they can hemorrhage. And is a whitish vaginal discharge okay? Yes, whitish is okay. That's normal. I worry if it changes color, don't I? Okay. Now, do you prefer this patient to have a shower or a bath? Shower, because baths promote ascending infections. Baths promote ascending infection. Other treatments that we have on your handout are radiation, like intracavitary radiation to prevent vaginal recurrence, chemotherapy, and estrogen inhibitors. Maybe the patient has a tumor that is real estrogen dependent. They'll inhibit estrogen in those people with the drugs that I have listed there. All right, let's look at breast cancer now. Breast cancer. One has a 3-fold increase of developing breast cancer if a first-degree relative, like mother, sister, daughter, had premenopausal breast cancer. Okay, so the history is really important here. Known risk factors: high-dose radiation to the thorax prior to age 20, like x-rays, that sort of thing. Period onset prior to the age of 12. Menopause after age 50. Again, somebody that doesn't have any pregnancies. Nulliparity, they sometimes call that. Or the first birth greater than 30. The longer you wait to have a baby, the greater the chance for reproductive type cancers. Signs and symptoms: change in appearance of the breast or a lump or the orange pill appearance. Now, what will the breast look like? Well, you may see some retraction, or like we said, the orange pill, that just means dimpling, retracts. That's when the breast tissue is retracted, that's that tumor inside pulling on the breast tissue, okay? And also discharge from the nipple as well can be a sign. Now, treatment, surgery. Post-op care is where we're going to focus now. Now, let me say one more thing about breast assessment. When you're teaching somebody about a breast assessment, you need to teach them to get into the shower first, right? And they need to learn what's normal for them, all right? Because everybody's got lumps and bumps. You need to learn what is normal for you. But we always say get into the shower because the hand will slide more easily over the breast when you're all soapy. They also need to be taught to examine under the axilla, too, known as the tail of Spence. The tail of Spence. The majority, 80% of breast tumors occur in the upper outer quadrant. 80% of breast tumors occur in the upper outer quadrant of the breast. Upper outer quadrant, that extends under the axilla, and that's known as the tail of Spence. All right, we're going to check for bleeding by checking the dressings, checking the back. Why are we checking the back, y'all? If the surgery's in the front, why are we checking the back? Pooling can occur. And remember, when you have pooling of blood, it doesn't always come out on the sheets where you can see it. You may have pooling of blood in the tissue back here. Also, we're going to check our hemovacs, and they may have some Jackson Pratt drains that we need to keep a check on, and watch for, anytime you've got drains, y'all, or suction, you need to look for sudden increases in bleeding or the amount that's there. Elevate the arm on the affected or unaffected side. Ask your friend. What you think? Hey, what does the unaffected side have to do with it? Nothing, right? So you elevate on the affected side, the surgical side. Because many times they take out lymph nodes too. Yeah, and when you take out lymph nodes in any area, swelling's going to occur. That's why we're elevating, okay? Also, that is why many times people will come back with like an ACE compression bandage on their arm to decrease edema. Too. That just depends on the doctor, but elevation is very important. Now, associated nursing care. Stay away from the arm on the affected side for the lifetime of the patient. They need to be taught, hey, you protect that arm. For instance, no constriction, so no blood pressures. Also, when I think of constriction, I think of blouses with elastic or wearing a watch. They don't even want you carrying a purse on that arm anymore because that's a type of constriction. No blood pressures, no injections, wear gloves when gardening, watch small cuts, no nail biting, no sunburn, no IV, no nothing. The least little, see, if you don't have your lymphatic system over here anymore, do you have the ability to fight infection like you used to? No, so one little old nick can turn into a major wound infection for me. Other things to remember post-mastectomy: brush hair, squeeze tennis balls, wall climbing, flex and extend the elbow. Why? Promotes new circulation. New circulation, sometimes called collateral circulation. Now, day one post-op, you come in the room and you say, okay, Marlene, I need for you to brush your hair, so you give me a hairbrush. First of all, I'm going to try to take it with the opposite arm because it doesn't hurt over here, does it? Okay? But you say, no, I really mean on the affected side, your surgical side. So I take the hairbrush. How am I going to brush my hair day one post-op? Like this, right? Why? Because it hurts. You're protecting. That's why they can get frozen shoulder. But that's why we got them doing these other things too, like the wall climbing exercises, because every day you want them to go up the wall a little bit further. All right, we want them to look at the incision. Now, that's not something they can do immediately. For different people, that takes different amounts of time. And, that's one way you can tell how well they're adapting and coping is how much they want to participate in their care, their dressing changes. And many women this day and time go ahead and after they've had the mastectomy, go ahead and have augmentation at the same time. That really helps with the body image changes. Reach to Recovery is the name of the support group. And then I also want to talk about lymphedema just a little bit more. This is just so important. You know, if you don't have a lymphatic system, we've already said that you can't fight infection over here, and the area is going to start to swell, right? That's two of the most important functions of the lymphatic system, is to fight infection and promote drainage. So that's why they really have to protect this extremity. And, forever, they may have to support that extremity. It depends on how much how many lymph nodes were taken out. But with time, they should be able to get to where they can hang their arm down. Some people don't ever get to that point. Most do. Okay? Other treatments. Chemo, like Taxol and adriamycin. Then you've got estrogen receptor blocking agents like tamoxifen. Estrogen synthesis inhibitors like Lupron and Zoladex. Those just really inhibit any type of estrogen. It's like puts them in a menopause because many... both those kinds of drugs do that. Many kind of breast tumors are real estrogen dependent. And then radiation may have to be done too. It just depends. All right, now let's look at lung cancer. The leading cause of cancer death worldwide, it's the 5-year survival rate is only 14%. Okay, so that's not very high. Of course, the major risk factor is going to be smoking. Now, when you have stopped smoking for 15 years, the incidence of lung cancer is almost like that of a non-smoker, okay? They're never going to say it's just like that of a non-smoker because you still have a history of smoking, but it's almost just like that of a non-smoker. Signs and symptoms, hemoptysis and shortness of breath. Now, when you have somebody that presents with hemoptysis and shortness of breath, many times that gets confused with TB. Something about TB, though, that makes it different is that TB people have night sweats, too. Night sweats. Now, other signs of lung cancer are hoarseness, cough, change in endurance, chest pain, pleuritic pain on inspiration, a displaced trach, and this may metastasize to the bone. Now, how do they diagnose this? Well, one way is with a bronchoscopy, just to go in there and look. MPO pre and MPO until what returns? Gag reflex. Now, don't get me wrong. When they come back from this procedure, it's okay for them not to have a gag reflex. That's normal because anytime they're passing a scope through the oropharynx, they spray stuff back there to numb you up, right? So when they pass the tube, you won't gag so much. But the key is this. If they don't have a gag reflex, you must keep them MPO because they could aspirate. It'll come back on its own. Now, watch for respiratory depression, hoarseness, dysphagia, or sub-Q emphysema. What is sub-Q emphysema? Air under the tissue, or under the skin, in the tissue. Air in the tissue. I bet your teacher told you something like this. It feels like Rice Krispies sound. Does that make sense? That's kind of weird. It feels like Rice Krispies sound. That's the air popping and cracking under there. If you ever have a patient who has air in the tissue, after a bronchoscopy in particular, they had to have perforated the airway, right? They're leaking air out into the tissue. That's an emergency. You're not just going to sit there and say, oh, you got the Rice Krispie thing, okay? Something's going on that needs to be dealt with. Also, is it normal or abnormal to have respiratory depression when they come back from this procedure? Ask your friend. I know what's going through your mind. You're saying, well, they gave them that stuff to make them pass out, all right? Knock them out, sedation, right? So, of course, the respiratory rate's going to be decreased. Well, a decreased respiratory rate is different than respiratory depression. That's an example of the way they'll get you on boards. They make you think, well, yeah, they had that medicine to put them to sleep before they put the scope down, so of course they're going to be breathing more slowly. Well, slowly is different than depressed. When you see the words respiratory depression, that means depressed less than 12 times per minute. So are we worried about that? Yeah. Now here's my rule for breathing, and I'll give you a second to finish writing down what you're writing down, and I want to tell you this. You're going to think, well, that is so stupid, all right? But you'll see what I mean when we start looking at test questions. The respiratory rate should always be perfect, period. Now you remember that when we start looking at test questions later on in the week. If it's too low or too high, there is a problem, especially after an airway test, okay? All right, sputum specimen. When is the best time to get that specimen? First thing in the morning. We like fresh specimens, right? Those secretions have been accumulating all night long. That's what we want. Is this a sterile specimen? Yes, it is. Now, I know what some of you are thinking. You're thinking when they cough and the sputum comes through the mouth that it is no longer sterile, and you're right. When it comes through the mouth, it's not sterile anymore, but do we still consider this to be a sterile specimen? Yes, you've got to have a sterile cup, the whole bit, and when they've got the cup there, the sterile cup, do you want their mouth touching the cup? No, you just contaminated the specimen. Now, what should you have your patient do first? I bet I heard somebody say coughing. Somebody thought that in their head. Before they cough, what should they do? Rinse their mouth out with water. Rinse their mouth out with water. Rinse the mouth out with water. We're trying to decrease the bacterial count in the mouth. Trying to decrease the bacterial count in the mouth. So when that sputum comes through there, it won't pick up mouth bacteria, is my point. All right, other ways they diagnose this: CT scan, MRI. And the treatment, well, surgery. The main treatment for stage 1 and 2 is going to be surgery. And you've got a lobectomy and you've got a pneumonectomy. Now, a lobectomy is just when they take out part of the lung, right? Yeah, part of it. You're retaining some of your lung. They're going to have chest tubes here. Because do you want fluid accumulating around the small part of lung you have left? So they're going to have chest tubes with that one because you've still got lung over there, okay? And you want the surgical side up. Like if say you have 3 lobes over here. They took out one of the lobes. You've got 2 lobes left. They want that lung, what's left of it, to be able to expand, is what I'm trying to say, so it won't get pneumonia. Now, what is a pneumonectomy? Yeah, the entire lung, removal of the entire lung. Now, position on what side? Affected or unaffected? Ask your friend. Tell me. Surgical side, the affected side. Good lung, only lung you have left, up, right? Yes. Because if you are somebody that put them on the only lung they have left because you want this big gap over here to be able to expand, there's nothing to expand over here, right? And if you put me on the only lung I have left, the only lung I have left is going to fill with fluid and I'm going to get pneumonia. So you put me good lung up so it can expand and not get pneumonia. Now, no chest tubes. Why do they not have chest tubes, y'all? No lung. Where do chest tubes go? In the pleural space. Well, if your lung's gone, you don't have a pleural space anymore, now do you? Now, I want to emphasize that we still avoid severe lateral positioning. In other words, when you turn them on their side, you don't turn them way up on their side, because that can promote a mediastinal shift, and everybody knows that's bad, right? And we're going to talk about that later, tomorrow, in the respiratory section. All right, let's take a break.